My name's Lara McLaughlin, and I'm here to present the Community Hospital Homeless Health Education and Learning Series workshop. Today's topic is Mental Health Crisis Service Navigation, and we're very fortunate to have with us three amazing speakers: Elaine Amsterdam from the Gerstein Crisis Center, Rochelle McAlister from WoodGreen Community Services, and Dr. Arielle Salama from St. Mike's Hospital. I just want to mention a couple logistics before we get started. The session is being videotaped with the purpose of providing staff who couldn't attend today with access to this information in the future. So you as the audience are not going to be videotaped, but if you ask a question, it could potentially be picked up by the mic. So if you ask a question during the presentation, can you just drop by and sign a form saying it's okay for your voice to be incorporated into the video? I'll also send you guys a copy of this deck to your emails. So just be sure that the emails that are on that sheet are correct. The washrooms are just outside behind the sculpture in the lobby. I think that's all. And then in terms of the plan, we're going to spend 20 minutes learning about the services that are offered with these three organizations. And then there'll be plenty of time at the end for question and answers. We have a case study that's incorporated as well, but if you have other case studies from your own practice around where you really struggled to sort out how to obtain the appropriate mental health crisis service for your clients, you can share those. You can ask questions throughout as well. Okay, get started. Elaine.
Hello and welcome. Thank you all for coming this afternoon, and thanks as well to St. Mike's for inviting us here today. My name is Elaine Amsterdam. I'm the Coordinator of Crisis Services at Gerstein Crisis Center. And I'm going to begin by giving you just an overview of some of the services that we provide. And I thought a little bit this afternoon about how I wanted to begin. I know you're going to be bombarded by information about our service, and certainly hearing plenty from the other speakers about the work they do. And I think that the way I would like to begin is to give you a flavor of who we are and how we began our service by speaking, and I'm just going to read it to you from our mission, vision, and values by way of introduction. So the mission of the Gerstein Center is to provide a community-based alternative approach to crisis intervention by delivering individualized, non-medical support to people experiencing a mental health crisis. Our vision is to be an accessible source of support and recovery to individuals experiencing mental health crisis, to work collaboratively with partners to create improved access to services, and to promote wellness, recovery, and strong consumer survivor networks. By means of values, respect, autonomy, dignity, diversity, collaboration, and accountability are at the core of all that we do. We value the whole person and acknowledge and respect their needs and wishes for recovery. So where I'll begin is with our crisis center on Charles Street. So all of our services are available 24/7, 7 days a week, clearly. We're available to both men and women experiencing mental health crises, including substance use and concurrent crises and complex needs. The crisis line is available at 929-5200. We have a referral line as well, so that folks can call individually when they are experiencing a crisis or struggling. Somebody can also call on their behalf. We have a mobile crisis team that can go out and visit people in the community. We take, I would say, roughly 25 to 30,000 phone calls a year, of which about 1,500 to 2,000 will translate into mobile crisis visits. So not everybody needs a visit, nor can we visit everyone we talk to, but we certainly recognize that with some crises, a face-to-face intervention is what's called for. We also have crisis beds for both men and women, can stay between 3 and 5 days to help sort of regroup, ground themselves before carrying on. So we take phone calls from pretty much anywhere in the city of Toronto. We actually occasionally take phone calls across the country and across the world. The catchment area for mobile team visits, though, is South Central Ontario. So roughly we're looking at from the Lake to Eglinton, from Vic Park to Jane. The next program is Gerstein on Bloor. We house two programs there. The first is Mental Health and Justice, which has 9 beds for men and women who have mental health crises, who are currently homeless and have current involvement in the justice system. Referrals must come from a justice provider, so we're taking referrals from the courts. People are coming straight out of jail, bail officers, probation workers, and even from the police. We also have 6 beds for women who are experiencing homelessness and persistent mental health issues who are in crisis. Those referrals can come from anywhere in the community. So I'm just going to put this up all together. What I want to do is just give you a flavor of some of the work that we do. So in the short-term residential beds, what we hope is that people will come in, they stay for up to 30 days, and they leave not only feeling a little bit regrouped and more able to make a transition back to the community, but have both some support and some internal sort of skill development with regard to crisis intervention and coping, at least some starting referrals with regard to housing, case management, culturally specific case management, discharge planning, court support, dual diagnosis case management, and through the youth courts and youth workers. So all of the programs that are part of the Mental Health and Justice Network, there are 35 beds across the city. So Gerstein is the downtown provider. We have CMHA, CODA, and Reconnect, who also manage the other 3 quadrants. All of the beds in the city have police access availability, so that there is always something available to the police to be able to divert somebody from an unnecessary involvement with the justice system. So at any point, the police can call a number and know where they can take somebody who may be struggling with their mental health and has had some brief involvement, and hopefully we can divert them from further justice involvement. We have a substance use crisis team, also takes crisis calls, has can do mobile crisis response, and we do follow-up for up to 30 days with that program, again trying to provide support for that 30 days, any kind of needed referrals that we can manage, and at least getting things started. You know, certainly I think all of us are well aware that there are limited resources available in the community, so if we can at least begin that process, begin that connection and provide support for 30 days, it can go a long way. We have 6 crisis beds that are for men, and they're for men really because we are being hosted within the Withdrawal Management Center at 16 Ossington, which is a men's WMS. So those beds will also take folks struggling with their substance use up to 30 days. So Gerstein has had a long partnership with the Griffin Center. What we've done is begun to participate in a new project with them. So the Griffin Center works with folks who have developmental handicaps and those that are duly diagnosed, so people who have developmental handicaps who are also struggling with their mental health. They have a new province-wide program which is referred to as URAH, or URA, which is Urgent Response After Hours, intended for adults 18 and over experiencing urgent and unmet developmental support needs. Clearly after hours, so between 4:30 in the afternoon, 8:30 in the morning, weekends as well as statutory holidays. Gerstein will take over for this response, otherwise the DSO is available for remaining hours, so there's 24-hour wraparound. The idea is that this is a police access number, so I would imagine by and large what we'll see is families calling in the police in the middle of the night, not able to cope with a family member who is in crisis, struggling with their developmental needs. Those are unmet needs at that moment and probably don't have sufficient connection within the community. We'll try and do some early bridging. The goal there really is to stabilize, de-escalate, and mitigate risk. So we really want to help people with their immediate crisis and then reconnect them with Griffin and the DSO come Monday morning. The geographic boundaries for this is really across the Greater Toronto Area, including Etobicoke and Scarborough. So the Emergency Reception Center is another project that is worth talking about. So in the event of an emergency that results in a prolonged displacement of residents from their homes, the City of Toronto and the Office of Emergency Management opens up an emergency reception center. So I'm sure many of you are familiar with the Parliament Street, with the electrical sort of outage there that displaced many people still to the fire that was at the Wellesley Street apartments, and they have to on the fly open up an emergency reception center. When that happens, Gerstein Crisis Center becomes the health service response coordinator. We come out to assess and coordinate a response for specific individuals in the ERC. So these are people with mental health and or substance use issues, seniors with dementia, or others with cognitive and developmental disabilities whose needs exceeds those that can be provided within the ERC setting. So these are people who are not doing well in the ERC because of specialized need. We come out to provide support, try and stabilize them so they can hopefully remain in the ERC or reconnect with supports they have in the community or develop new pathways for support that will help see them through a period of more intense crisis. We have a good deal of partnership in the community for this, including community health centers, family health teams, primary care through ITCHA, social service partners through CODA, CMHA, COSS, WoodGreen, Reconnect, and Toronto North Support Services. This slide is probably fairly large and difficult to read from where you are. It's meant to really give you an idea of some of the pathways to service. So in terms of access, the vast majority of folks come to us themselves. They are going to self-refer, be referred by family and friends. Next, we get the greatest number of referrals through hospitals and emergency departments, and then from other community agencies. We have a number of core programs, which I've mentioned, the crisis program, substance use, mental health and justice, and we have a number of recovery-based programs, including training, education, and employment. Referral partners in the community are multiple, so we, through the Mental Health and Justice Network, through addictions and substance use, other crisis services, and referral pathways are really endless. And the idea, to give you an idea, through access point, case management, youth programs, income, medical, etc. You can have a look at this a little bit later to get a little bit more detail. So one program I'd like to highlight, because I think it really speaks to some of the service navigation activity that we've come to talk about today, is a fairly newish project called Mobile Crisis Intervention and Follow-Up. So the City of Toronto and the Toronto Central LHINs requested enhanced 24-hour mobile crisis intervention services in the downtown core in the Mid-East. This is a collaborative program with Gerstein and a number of partners who I'll name. Soundtime, St. Stephen's TCAT program, St. Mike's ED, the Rapid Access and Addiction Medicine or RAM Clinic, and a Schnobby RAM, Regent Park CHC Outreach, Sherburne Health and Street Health Bus, the Access Point NEMDOT, and the Mideast Virtual Hub. So who the project serves is, again, adults 16 and over in the downtown core who are in crisis related to a mental health and addiction issue. Concurrent disorders or problematic substance use are often going to be a core issue for this population. And individuals may have frequent contact with hospital EDs, EMS, police shelters, and other community services. Individuals, of course, are also facing other needs, including the social determinants of health, unstable housing, poverty, experiences of trauma, and physical health issues. So what we did is we wanted to have streamlined access, and the access is intended to be for the overnight drop-ins, for outreach workers, harm reduction workers, and St. Mike's ED. We set up a new phone number that was intended only for this group to be able to call our crisis team directly. People in crisis are still free to call the crisis line on their own, but this is an added resource that we hope would streamline a response. So the Mobile Crisis Intervention and Follow-Up team is integrated into the other crisis team at Gerstein, which means they are available between 10 a.m. and midnight, and then the regular crisis intervention will take over from midnight till morning and on the weekends. We provide an immediate crisis response, so when we receive a call from somebody making a referral, we try and get out there within 40 minutes and 4 hours. This is followed up by a wellness check within 24 hours. So we want to do a second check-in to see how that person is doing. And part of that came from any number of research that we looked at that seemed to indicate that anybody who was discharged from hospital from almost any reason, so any kind of surgery, any other kind of need, when they received follow-up within 24 hours, that it tended to indicate a 30% drop in a return to the emergency department for non-emergent reasons. So we were hoping to reduce the return to the ED for unnecessary service if we could get in there quickly and then get in there again within 24 hours. So there are no new beds associated with this project. The emphasis has been placed on crisis intervention and follow-up in the community. We're able to provide up to 30 days and then make referrals to any of the partners that I mentioned earlier. We try to take a very low barrier response, as we have with our other programs, and have a kind of go and see what we can do approach. So in terms of a referral, we looked at a very low threshold. We're trying to get out there to see people who have mental health crises, crises that could be substance use related, concurrent related, or other complex needs, and that's simply, what you think is happening, whether the ED thinks something has happened, or when the outreacher feels that somebody is not doing well and it's more than what they can provide. As long as safety is not an immediate issue for the person in crisis or for the team that's going out, as long as there's no immediate medical needs that we can't respond to because we're not a medical response, and that there's no, sort of real immediate risk. One of the things that we do is provide suicide intervention. So if somebody is thinking about suicide, whether they're calling our crisis line or in one of our programs, we work with them around that. If they've already done something to hurt themselves, it becomes a medical emergency, and then an emergency response is needed. But otherwise, we probably work with folks with suicide thoughts on a daily basis. The geography for this response is specific to, but not exclusive to, the Mideast. The concentration is the downtown core, so services focus on Bathurst to Broadview and from Bloor to the lake. So to give you a sense of referral pathways, in part because we're talking about it today, so how it begins and how it is traditionally is the client and the referral partner will make a referral to the Gerstein Crisis Center. We provide immediate intervention and potentially up to 30 days of support, and then refer to service partners if the person needs additional support or referrals in the community. And that's sort of a straight line. What we hope for in the end is to create a new service pathway that's more circular, so that the client has any number of doors that they can open to receive service when they need it, and the service that they want in a particular moment. So they're free to go back and go back to the ED or go back to the outreach worker. They can also now call the Gerstein Crisis Center directly. They can call the other service partners directly, and the other folks within the referral core can also speak to each other and work collaboratively to provide a more coordinated service response. In the end, this is what we hope for. Individuals have access to the supports they need when and where they need them. A lot of what we do is 24/7 because we really recognize that crisis is not a 9-to-5 thing. And when we add in other social determinants of health, or other complexity of need, we know our folks are not the let's make an 11 a.m. appointment and we'll see you soon. The crises can happen anytime, and we try to go to where the person is rather than having them always come to us. To reduce the need to go to the emergency room for non-emergent reasons, greater service collaboration and coordination, improving communities of practice. Workers feel better connected and supported. So a lot of the work that we do and a lot of the work that you're doing often feels like it's being done in isolation. The work is stressful and people have only each other to talk to. So to build communities of practice in which there's a greater network for people to get support, I think leads to a better working experience and greater collaboration. Also, ongoing gaps are better defined for future service improvements, and that's information that we regularly will communicate to the Toronto Central LHINs and to other partners in hopes of continuing to build greater crisis response in our communities. So that's it for me.
Thank you, Elaine. So my name is Rochelle McAlister. I'm the Senior Manager of Seniors Mental Health and Addictions at WoodGreen Community Services. I'm here today to talk about a couple of the programs I oversee. So I thought since this is about mental health crisis navigation, I would define crisis. This is the definition that we use for COSS and Toronto Seniors Helpline. A crisis occurs when an individual experiences a change which makes them feel uncomfortable, which makes them feel like they're unable to cope in their usual way. So I'd like to tell you about the Crisis Outreach Service for Seniors, or COSS for short, and this is how you access COSS is through this phone number, 416-217-2077. And we are serving seniors, so generally we're serving older adults who are 65 and above. Sometimes we serve seniors who are between 65 and 64 if there are some geriatric presentations or geriatric concerns. We serve the City of Toronto, so the idea is that wherever you are in the City of Toronto, so any postal codes starting with M, you can access high-quality crisis services. This was not the case several years ago, but about 4 years ago, we joined together with several different organizations to make sure that there was equity across the city. We generally serve seniors who are living in the community, so usually not in long-term care or retirement homes, just because they have a lot of supports in those settings, but we can consult with staff at those agencies or family members who have loved ones in those types of settings. Generally, the COSS clients are frail or isolated, marginalized, low income, and at risk in some way. Sometimes homeless or underhoused. We see a lot of seniors who are facing eviction. Seniors who are hard to serve, hard to reach, and seniors who are at increased risk of using the emergency department and inpatient hospital services. Just a word about consent. So we do not require consent to make a referral, and we don't require consent to make an initial crisis visit. So sometimes the seniors know that we're coming to visit them, and sometimes they don't. It depends on what kind of information we have. When we go to the door and visit, consent is needed to continue that follow-up service. Obviously, no one is forced to work with us, so the staff are amazing at building rapport at that initial visit, trying to find some ways that will be interesting for the senior to receive help, but they do need to consent to receive help. But we don't need consent for that initial visit because of the risk. Anyone can make a referral to COSS, and you can be anonymous if you want, but the more information we have, the better. So this, as I said, COSS serves the City of Toronto. We do have 3 different teams: COSS North, which is north of Eglinton; COSS West, which is west of Yonge; COSS East, which is east of Yonge. So WoodGreen partners with Loft and Reconnect, South Riverdale Community Health Centre, and Haven, Toronto. So the partners all came together so that we'd be able to make this a regional service. The service is quite the same across the different organizations and the different COSS teams, so you just need to know you're calling COSS. So what types of crisis situations is COSS responding to? So a lot of situations where seniors are not coping well with living independently in the community, and we also have a strong partnership with the various LHINs, and particularly the Toronto Central LHIN. Seniors who have complicated grief, seniors who are not managing the process of aging well, seniors with challenging behaviors. We recently have hired behavior consultants on the teams who can specifically look at challenging behaviors and from a behavior lens know how to support. Seniors with mental health concerns, substance use concerns, or both, and we have some specialization on the teams for concurrent disorders. Seniors with challenging behaviors related to dementia, seniors posing a risk to themselves or others, those who have repeated usage of emergency departments for non-medical issues, those who have sudden, unplanned, or uncoordinated hospital discharges, seniors who are being evicted. As we know, there's a housing crisis happening in our city. So I must say that COSS they are not housing workers, and yet a lot of the seniors that we're seeing are in housing crisis. Seniors with bed bugs, pests, hoarding, unwanted guests in their homes, experiencing the possibility of elder abuse. So we get many allegations of elder abuse or suspicions that elder abuse might be happening. So COSS can go out and make that in-person assessment with them and do some safety planning. As you're likely aware, most people who are experiencing elder abuse don't actually want to do anything about it. It's usually from a family member or someone that they care about, and so they would rather stay in the abusive situation, and obviously that is their choice if they're capable to make that choice. So often it's doing safety planning. On occasion, a senior does want to leave that situation, and we've had some dramatic situations like that. We have a really great relationship with the police that can assist in that matter and connecting with how to get them to leave that situation. Also, caregiver burnout. So this is a big issue also. Informal caregivers, family members who have been helping a senior and are feeling burnout, so COSS can support them as well. So generally, seniors with complexities who we're seeing, we sit at the Spider and two of the focus tables. So those are coordinating bodies that are helping people living in Toronto with complex situations, and so we're usually assisting those seniors. So what do we offer in a crisis? So there's a 2-person outreach team. So there are crisis workers, and between 9 and 5 every day of the year, we go out and make those initial crisis visits. So in-person contact is made, we say, within 72 hours. Usually it's the next day. And offering comprehensive care in the community. So there's short-term crisis counseling and case management, such as initiating community services, for example, personal support workers, home care, Meals on Wheels, specialized older adult services, and day programs. There's supports and strategies around harm reduction, mental health, addictions, and responsive behaviors. We're able to offer health assessment and care as needed. So we have a nurse practitioner on the East team. There's a geriatric psychiatrist that is available to us. There's behavior consultants and linkages to long-term primary care. Generally, COSS supports people for 6 to 8 weeks. That's not a hard and fast rule, but sometimes it's just an initial visit and that's the end of the work. Sometimes it's between 6 to 8 weeks. Through our partnership, WoodGreen, Loft, and Reconnect, we're able to offer follow-up case management support for up to a year. So if the person does need follow-up case management after the 6 to 8 weeks, we facilitate that with no wait lists. There's also emergency PSWs for crisis resolution that's accessible to COSS clients, and there's a short-term shared respite unit where clients of COSS can stay for a very short term, about 2 weeks. We also offer consultation to service providers working with seniors. So sometimes case managers will call into COSS and they want to continue working with their client, but maybe they don't have that seniors expertise or they've tried a lot of things and just want someone to do consultation with, and so COSS provides that. All of the intake is done through the Toronto Seniors Helpline. Again, that number 416-217-2077. So more about Toronto Seniors Helpline. So at Toronto Seniors Helpline, we have 8 full-time staff, and they're all registered professionals, and 3 relief staff. We operate every day of the year, but not 24/7, so it's from 9 a.m. until 8 p.m., Monday to Friday, and from 10 to 6 weekends and stat holidays. Again, we cover the city of Toronto. We do get calls from other cities, other countries sometimes, but we're focused on Toronto, and we have a 1877 number. We use telephone interpreters, so telephone interpretation is not a challenge. We have over 100 languages available through that. If you don't get a live answer when you call in, you can leave a voicemail, and the voicemail will be returned by the next day. And very new to us, we have a live chat feature. So we have a new website, torontoseniorshelpline.ca, and now we have a live chat feature. So for people that prefer to do chat than the phone, you can use chat. I must say, because there's a lot of privacy concerns around using a chat feature. So the chat feature is mainly for giving out information on services that are available. If it's a supportive counseling type of situation, we encourage people to call. And if it's a crisis situation, we prefer you to call as well. So Toronto Seniors Helpline. So one phone number, wanted to make it as easy as possible for seniors and caregivers to be able to get support. So through that one phone number, you can get crisis services, services for seniors and caregivers, community supports, home care supports, short-term supportive counseling over the phone, and consultation around complex clients. In terms of the community supports, so we have developed a relationship with all of the service providers who offer community supports in the TC LHIN. So we have updated information. So if you're looking for services for seniors, they'll have that information they can give you at Toronto Seniors Helpline, and we can refer appropriately. Again, seniors don't need to know who's the agency in my neighborhood. We can figure that out for you. In terms of home care, we work really closely with the Toronto Central LHIN, and so it's easy to facilitate intake for things like occupational therapy, physical therapy, or PSWs. And in terms of the supportive counseling, so seniors who are grieving, lonely, struggling with caregiving, or struggling with their caregiver, seniors who are worried or anxious, we can give that supportive counseling over the phone. So sometimes we have people who are calling in just once and they're having a challenging time and they just want to speak with one of the staff. And to be honest, sometimes we have people who are calling every day and just trying to break that isolation and wanting to get crisis support or support over the phone. So there's our number again, Toronto Seniors Helpline, 416-217-2077, and our website. I don't oversee this program, but wanted to talk a bit about the walk-in counseling that's available. So just in terms of mental health crisis support, we know that it can take a long time to get a counselor or a psychotherapist. At WoodGreen, we have walk-in counseling Tuesdays and Wednesdays from 4:30 until 8:30. So registration opens at 4:15 and it closes at 6:45. So as long as you come within that time frame, you will see a counselor that night. And it's at 815 Danforth, and the phone number is there. So if you're able to make it to that location, again, in those hours, you will be able to see a counselor. Also, it's available at the Yonge Street Mission Thursdays from 4:30 to 8:30. Registration opening at 4:15, closing at 6:45 again, and that's at 270 Gerrard Street East. So this is a really accessible way to get counseling support. At WoodGreen, we use a combination of WoodGreen staff plus volunteers from the community who are all registered professionals. They use various counseling modalities, and it's a way to just access support quite quickly. We thought we'd just give some other helpful phone numbers. So the information is there for the emergency shelter central intake, so people needing to access a shelter. I should say that with COSS, there's a rumor going around that we have secret housing, and it's not true. So unfortunately, we do get calls, a senior's about to be evicted, can you find them housing today? And it's impossible. I shouldn't say it's impossible, it's very highly unlikely. So unfortunately, we are often accompanying seniors to shelter. We know that that's not an ideal situation, but again, we're in a crisis situation, so this is the number for accessing shelters. There's the Streets to Homes Assessment and Referral Center at 129 Peter. There's a number there for Telehealth Ontario, as well as the Children's Aid Societies. Lots of different crisis lines. Toronto has plenty of crisis lines. So we have Gerstein, of course, Toronto Seniors Helpline, the Toronto Distress Center, Scarborough Mobile Crisis, the Assaulted Women's Helpline, the Toronto Rape Crisis Center, First Nations and Inuit Hope for Wellness Helpline, and they have an online chat as well. There's the Warm Line through Progress Place, which offers call and text, the Warm Line through the Krasman Center, and the Kids Help Phone. Toronto Withdrawal Management System has a centralized intake, connects Ontario Drug and Alcohol Helpline, connects Ontario Mental Health and Gambling Helpline. COPA is a great program through which is available for seniors with addictions, and that's operated through Reconnect. Of course, there's a TC Lynn for those needing home care, and Housing Help Centers through 211. Thank you.
Hi. Sorry, thanks everyone for coming. I'm Dr. Arielle Salama, and I work here at St. Mike's. And one of the things I do is work in what we call the MHESA, Mental Health Emergency Service Area. You might also hear it referred to as PES. That was just the older name before the renovation. That means Psychiatric Emergency Services, so those could be used interchangeably, but this is the current official name. So this is a psychiatric emergency department. So it's located within our larger emergency department, and what that means is that everyone is seen. There's some exceptions, but very rarely. Typically, if a patient is to be seen by us, they have a referral from an emergency doctor. So they've gone in, they've seen an emergency room doctor. The emergency room doctor thinks it's a good idea for them to be referred to our service. That may not be the model at every single emergency room in the city or elsewhere where you work. It's not the model at CAMH because they're not running within a general emerge. It's even within other hospitals that are academic hospitals and have a similar setup to us. It may be slightly different, but that's how it works here. So who works in the MHESA? There's 4 nurses there working at any time. 1 psychiatrist during the day, so during 8 to 6, there will physically be a psychiatrist there. During the evenings and parts of the weekends, that psychiatrist may be doing home calls, so they may be available by phone only. They're not going to physically be there. There will always be, at nights, 1 or 2 residents there, so there is a physician physically available. During the day, I have anywhere from 0 to 3 residents working with me, and 0 to 1 or 2 medical students. So the team can be as small as 4 nurses and 1 psychiatrist, or about double in size if we have a lot of learners working with us. There's also a security guard, or there's multiple security guards within the emergency room, but there's always 1 stationed within our physical area. Additionally, we have collaboration from other parts of the hospital, so the emergency room itself, other medical specialties, the addictions consult team, and social work are typically they're not located in our physical area, but they'll come in and out to work with us. So the physical space, I know some of you have been in there, it's changing. Supposedly will change to the newer site in a different part of the hospital in spring 2020, but that was supposed to happen 2 years ago, so don't show up on spring 2020 expecting that. Right now, it's physically a bit of a closed off area within the emergency room, right past the triage doors. There's 8 patient beds in there. 3 of them are more seclusion rooms. The other ones are kind of typical, just sort of open curtain rooms. When we have more patients than that, which is frequently, they're in the other part of the emerge, acute or ambulatory. So they'll be cared for by the emergency room nurses, and we will be sort of running back and forth to see them when we're able to. There's a nursing station in the middle, and the patients are kind of all around, which means confidentiality is poor. Patients hear each other, and they hear us discussing cases and working. There's 2 patient restrooms. Unfortunately, right now, we cannot offer our patients showers or decontamination rooms just due to the way the physical renovations have gone on, which can be really unfortunate, as we'll have patients staying with us sometimes for quite a while, and we can't always give them the adequate services that they need. There's a little reassessment chair area, which patients might be seated at. Some of you may have come and seen patients who are waited in that area if they don't need a bed anymore, and either we're planning to discharge them. If they're just waiting for something, they may be seated there, but it's still within the department. So the mix of patients that we have in our area could be patients who are awaiting a consultation, patients who have been admitted to stay for a short time just down here in the emerge, and patients who have been admitted upstairs, but there's no bed, so they're with us for a while. So this is probably pretty hard to see. I took this from sort of one of our official documents from the hospital, but essentially this is the pathway to how a patient would come to us, which means that basically with the emergency room, we have a collaborative model of care. So elements of our team, such as nurses, may be involved from the get-go, the second the patient registers at triage. If it's a patient that we know, if it's a patient that we've heard about, if one of our outpatient teams has asked us to see the patient, if it's a patient that the emergency room anticipates will be referred to us, we may kind of start working on the case prior to the referral. It may be that the emergency room spends a day, or typically less than that, working up the patient, and then they transfer to us. It's very rare for a patient to come directly to us without an emergency physician having triage or having evaluated them, but there are situations where that happens. So basically, this is kind of the flow chart for that. There might be questions about it later, but I just wanted to kind of simplify this. A lot of patients do arrive at triage with a mental health, psychiatric, addictions concern as their primary problem. So theoretically, they'll be triaged to our area, which means like physically put in our area, whether we as psychiatrists end up getting involved or not. But that's not always the case, depending on sort of the severity of their concerns, if there is a potential medical involvement, if they are acutely agitated. So they may or may not physically end up in our area right off the bat. So how do patients arrive to us? Often people bring themselves in, they walk in or, self-present. The police may bring them in. The police might have been called by the person, might have been called by a family member or friend, or bystanders if they observe something concerning. Family or friends may bring someone in. Sometimes an outpatient healthcare provider, such as their family doctor, will either ask them to come in or put them on a form and bring them there. Or casework or other supports often do bring patients in, whether they're aligned with our hospital or not. So then just to the status of patients once they're in, or what we call the status, once they're in our area, is that they could be voluntary, which means that they essentially are free to come and go. They could be on a Form 1, which means that they are not free to come and go. They're under an order for 72 hours, and they might be in one of our seclusion rooms too. A Form 2 would be something that someone from an outside party, a caseworker, family member, or another physician who hasn't seen the patient in the last week has a concern about the patient, thinks they need to be put on a form, applies to the justice of the peace, and has the patient brought in by police. until we assess them. They're under the Form 2, but then we would either put them on the Form 1 or allow them to be voluntary. So that's usually a pretty short-term thing. Form 47, so for some of our outpatient teams that follow patients who are on a CTO, community treatment order, if they have breached their community treatment order, such as by not getting their medication, a Form 47 is released, which means the police brings them into the hospital. Sometimes we don't see them if it's just to get medication or have something else like that, and it's straightforward. Emergency room takes care of that, or one of our nurses collaboratively takes care of that. If their team is concerned or there's something more unusual than their normal presentation, then we'll typically get involved for a consultation. Patients can also be under police custody, which typically we try to minimize once the emergency room doctor or one of us has spoken with the police. Typically they'll release them into our custody, and then it's kind of up to us to put a form or not, because there are different systems that don't always work super well together, but we try to kind of make that as seamless as possible. So I thought people might wonder what are some of the common reasons why patients present to the MHESA or self-present. The typical sort of concerns that we see from people are acute psychotic symptoms, manic symptoms, so kind of similar, depressive symptoms typically that have worsened, that may or may not include suicidal ideation, or some people have suicidal ideation without necessarily a depressive diagnosis. People who have attempted suicide but are medically stable. So if people take an overdose or have harmed themselves in any other way, they're typically going to be seen by the emergency room, maybe admitted to internal medicine, maybe admitted to surgery, depending on what happened. Once there's not anything ongoing from a medical viewpoint, or whatever's going on is mostly managed and we can handle it from there, then they would be referred to us. Sometimes people attempt suicide and it doesn't necessarily have a severe medical impact on them, and then they might go to us a little bit faster. We see people with substance intoxication or withdrawal. By no means do we see most of the patients who present to the emerge with those conditions, but we see some of them, particularly if they have a psychiatric history or there's unusual aspects to their intoxication or withdrawal. Any other kind of bizarre or agitated behavior, other crises. So as you guys have seen, there's probably a lot of different possibilities. Or again, psychiatric consequences of a medical illness if stable. So sometimes we get patients who are actually delirious due to a medical illness. It's not really psychiatric, but it takes us a while to figure that out. Sometimes people are on medications that cause an odd psychiatric presentation. So those people have typically been assessed by emergency and maybe medicine for quite a while before they come to us. So there's also non-urgent requests to see us, and they may not end up being triaged to us. So there's plenty of requests every day from patients coming in or being brought in that I would never see, that wouldn't necessarily either physically come to our area or come to our area but are not referred to us. They may, however, receive psychiatric care from the nurse working with the emergency team. So I just thought of some examples of recent ones. Again, some of these patients could be consulted to us. It really depends on a lot of different factors. But people sometimes are requesting a consultation, but there's nothing urgent or life-threatening going on. Typically, again, they'd be redirected towards their family doctor or another service. If they have chronic symptoms that are not really changing, but they're looking for, again, an assessment of that, they might be referred back to their outpatient doctor if they have. People who want a medication change or a refill of their meds, housing or socioeconomic concerns. As we've talked about, there's a housing crisis in the city that puts a huge amount of pressure on people coming to the emergency room, because often part of their presentation is that the place that they're staying is not appropriate for them and impacts their psychiatric health quite a lot, but it doesn't necessarily come to us. We may or may not have social work see them in that case. Capacity assessments around medication or financial decisions, or requests for counseling or therapy. So what would happen if someone is referred to us for an assessment? Assessment and consultation mean the same thing in this context. So ideally, we would get to interview the patient and speak with any collateral sources. So that would be their past records. We have a system that different hospitals in Ontario are connected online, and we can get some of their records. Any interviewing, if we can get a hold of their family or friends, and if we can talk to any care providers, physicians, or otherwise who have worked with the patients to get a sense of what's going on with them. We'll write a consultation note, which will include a tentative diagnosis or list of diagnoses. It'll include a focused psychiatric history, so probably less comprehensive and more oriented towards the present than would be on a typical consultation note. And it'll include, as much as we can, ideas around what the next steps are for care and disposition, whether they're being admitted or not. Part of our assessment will include our ideas of whether the patient needs to be voluntary or involuntary. We will often order medical tests, blood tests, x-rays, anything else that's needed. If required, if patients are agitated in a way that's threatening to themselves, that is a safety concern, then we may have to manage that, and that's when sometimes chemical or physical restraints can be involved. So the typical outcomes for the patients that we assess, so if we deem them to be involuntary, it's called certification, we put them on a form, then the plan would be either we admit them downstairs for a brief stay, or we admit them upstairs. Again, that could mean physically they're downstairs either for the entirety of their stay with us or for part of it. In the inpatient ward here at St. Mike's and at most of them, there's different levels of acuity from a general ward to an acute care ward, which would be more seclusion, higher nurse to patient ratio, more security. They could get a voluntary admission, so they're free to leave or stay, but they agree with us that they should stay here. That oftentimes that'll be a short stay downstairs, and they emerge for, we'll call that a crisis stay or a PSU stay for up to 2-3 days, or to the ward upstairs. Or sometimes we may end up transferring them to another hospital. Typically, we don't have enough beds, which is why people are waiting downstairs in the emerge. Other hospitals suffer from the same problem, but sometimes there's a gap and we can transfer someone. They may be discharged from our emerge. We may have connected them to services in the hospital or community, such as the services we've heard about. We may provide them with a prescription. We may give them information about other resources. Also, sometimes patients leave against medical advice. If they're not certified, if they're voluntary, either before they've seen us or after, even if we want them to stay for more medical testing or to see our addictions team or to do something else with us, they may choose to leave. So just some of the services we typically refer people to. Catch Homeless is a service that we refer to a lot for people who are NFA to get further either medical care, case management, and sometimes referral to psychiatry in the short term. We have an urgent care program at St. Michael's, which I work at as well. So for certain patients who don't have a following psychiatrist and do need short-term psychiatric care, we provide them with that. We might refer back to the patient's family doctor and suggest a referral to another service, particularly if they're not in our catchment and there's nothing urgent, or do other kinds of collaboration. See if there's any other community agencies that would apply to them. We have our addictions team that may have done a consult and may have referred them to their RAC clinic, which is sort of a walk-in addictions clinic that occurs 3 times a week. And CDSS is another service they often make use of. COSS, we may send someone to return to a shelter or help them get a detox bed. So other urgent services that we tell patients about include going to their family doctor's office if they have one and that's available, calling crisis lines, Gerstein crisis. So RAM, those are the rapid access addiction clinics. We have one at St. Mike's. Many of the hospitals in town thankfully have them, which means they could be seen around support for managing their addiction as long as it's not medically necessary that they stay in hospital right at that moment. For people under 25, there's some walk-in clinics that include counseling and some ability to see a psychiatrist that are called What's Up clinics. Family Services is another, has walk-in counseling as well. Some other agencies we make use of are Soundtimes, Reconnect, CMHA, CODA, or WoodGreen. And if people are eligible for it, we get a lot of Ryerson students coming. They can sometimes go to campus services where they'd either be able to see family medicine, a psychiatrist, or a counselor. So I just mentioned something about confidentiality because I think in the case study that was referred to, there was, did you guys see the case study? It was basically that a patient is brought, yeah? Oh, okay. So just essentially, like a patient is brought into the emerge and they are discharged within an hour, and the agency is not informed about this. So confidentiality, we have to go by the PHIPAA. When someone has a circle of care, well, everyone has a circle of care, which is usually to say other physicians and other caregivers that are involved in the patient's care, we have the right to speak to them about patient care. We take into account patients' wishes, patients' capacity. If they're involuntary on a Form 1, they have less ability to advise us in terms of who we can speak to than if they're voluntary. The patient's always entitled to a printed discharge document, and we send our full consultation and discharge note to the family doctor or any other specialists that see the patient. ER themselves, if they're only seen by ER, it's a briefer note. We may also provide them with information such as prescriptions, sick note, etc. So yeah, with the case scenario, there could be a lot of different questions to find out. I guess we'll discuss it more in the one-on-one, in the Q&A, but in this case, it's hard to know what happened if the patient was even registered. We sometimes have patients who are in the waiting room and they don't register. They either choose to leave or something else happens. They may have registered and then left before being seen, especially if it's a long wait. So were they seen by a nurse, like the triage nurse, the emerge nurse, an ER physician? Were they referred to us? Sometimes patients arrive as a John Doe. They don't have identifying documents or contact information, and we may not be able to contact anyone. And did they request for us to talk to anyone? Those are some of the questions that would run through my mind in those cases. So what can agencies do to ensure we understand their requests if they send someone or advise someone to come to the emerge in case of crisis? If you have any concerns, put them down on paper, write a note identifying who you are, how to get in touch with you, what exactly your concerns are, how long they've been going on, any information that you have, any specific needs the patients may have, any contact names and numbers for anyone we can get involved with that are really helpful, any useful documents, such as if they have another care plan, recent prescriptions, information about their care. You can always call our service if you have a patient who you think is admitted and ask to speak with one of us. We may or may not be able to give a lot of information, but if the patient's there and they're medically stable, we can at least give that information, and then we can always ask the patient if they want us to meet with you or if they want you to come visit. Okay.
Wow, that was amazing. Tons of information. Thank you so much. It's fascinating. So I think, this is a great opportunity for you to come up with questions that you think these speakers may be able to help you resolve. I mean, we heard about various lines, beds, the emergency department, and I think it would be interesting perhaps to think of a case where, you weren't sure what to do for a client who was having a mental health crisis, or you tried to do something for a client that was having a mental health crisis and you didn't get the outcome that you had hoped for or that the client needed. So I would just encourage you to ask those questions and share those stories.
Maybe just a quick question for COSS support. For the initial visit, do you also offer language specific?
Do you want to come up? Just repeat the question.
So I'm just going to repeat the question. So for COSS, when we go out, do we also offer language support? So we do. And so we can either use a phone interpreter or we can book an interpreter to be in person. So sometimes the referral source will state what their preference is. And yeah, so it depends, but we can either access the in-person or the over the phone, and we'll make that call, or if the referral source has an idea of which would work better. Sometimes having more people is intimidating, sometimes it's better, sometimes the phone's better, but definitely. Yes. Great question. So I hope I repeat it well. So when we're working, when COSS is working with clients, do we have the capacity to do long-term care capacity assessments? Yes. Do we have the ability to connect with the LIN to launch the capacity care evaluation? I think that was it. So yes, we do. So definitely we're working really closely with the LIN. So if they already have a LIN care coordinator, then the COSS would connect with them right away in terms of that long-term care capacity evaluation, which I'm sure most people know only the LIN can do that capacity evaluation. So we'd connect with that person. If they weren't connected with the LIN, then we could do the intake for that, connect with the right people, and make sure that that happens. Yes.
If you have like someone, a senior in shelter who requires emergency PSW services or like ongoing emergency PSW services, is it better to go through COSS or through TC-LIN directly?
So the question is, if a senior is in shelter and they need some emergency PSW services, is it better to go through COSS or the LIN? It can be either way. So what we're trying to do in the system, which is not always successful, is to have no wrong doors. So whoever you call will hopefully figure that out. So it could be either way. Generally, the PSWs, I would say, try the LIN first. They do send staff into shelters. If that doesn't work, we could try COSS, but I would try the LIN first. Other questions, case scenarios, suggestions, comments?
So if someone was to walk in for those services, say, 1 week on Tuesday, the next week if they showed up for the same service, would they be less of a priority because it's an emergency service and would they be directed to a more permanent counseling source? Or would it just be taken with open arms and every week they could do that?
Good question. I'll try to repeat it well. So if someone comes to the WoodGreen Walking Counseling Program and they come on a certain week, if they come back the next week, would they be less of a priority? Would they be redirected? So I'll just clarify, it's not an emergency service, and all of these sessions are treated as single session. So I should have mentioned that someone can come only once or they can come back as many times as they want, and each time it will be almost as if they're a new client and working on things as a single session. The person, if they were not seen and in that session, they'll receive counseling but also case management, so they might receive referrals in that situation as well, but there's no priority given. As long as they come by 6:45 and sign in, they will see someone. At the back. Question is there a case study? So that was just, the one that we got was this one. A client with suicide attempt in program is sent by staff to hospital, discharged after an hour. So we kind of reviewed that, but we are very open to other case studies or scenarios that you have. Yes.
Salama. The urgent services in the community, what's up in a career? You mentioned 25 and under. Is it 16, 25? Nothing?
That's a good question. I don't know. I'm sorry. The question was about the What's Up clinics for youth in the community, which we sometimes suggest to our patients under 25 if they need some more crisis supports. And the question was, is it for ages 16 to 25? I'm actually not sure. That sounds about right to me. Another resource that's similar to that is Stella's Place, which is for people under 30. So at least a little bit more of a population, but I'm not certain.
What's up stops at 25?
Yeah. And Stella stops at 30. Yeah.
I have one for you. I'm curious with the URA team. If you're referring to one, do they require a diagnosis of needing like developmental support?
Okay, so I'm just making sure I've heard the question correctly. So you're asking whether or not there needs to be a diagnosis of it. I think there needs to be a presumption of that, so that the perception of the person making the call is that there's a cognitive or a developmental disability. We're not going to look for a specific diagnosis or worry that there's something formal in place. Okay, so I only heard part of the question, but I think you're talking about folks who are being referred to the crisis programs who also may have physical disabilities?
Yeah, no, that have like kind of, that we're seeing it emerge with like cellulitis or open wounds, and they do require ongoing wound care.
Yeah.
But they're not going to be admitted to hospital. They are having other issues in their life, but do require that wound care.
You know, we don't provide that care. I can say that we don't have any medical staff on site, so the question was whether or not we're able to provide medical care. We can't provide that directly, but if we can arrange to have appropriate medical care, we do have space available that are wheelchair accessible or that allow for main floor use of our facilities. So to the degree that we can, we will.
So I can make a referral to the Lynn for PSW at a justice bed.
You can, as long as, but that would, just understanding that we don't do those, we can't provide that care. If that care can be provided, I don't see any reason why that wouldn't be accommodated. Hi.
Christine, would you offer long-term clinical counseling, like psychiatrists or psychotherapists?
So the question is whether or not we provide long-term psychotherapy or psychiatry. The quick answer to that is no. So we don't provide psychiatric services, nor do we provide therapy. We do provide crisis counseling, which is fairly immediate. People may call and speak to the same person. They may call and speak to a multiple people. We want to make sure that people are able to take value in whomever they talk to whenever they call. So it's not sort of intended to be ongoing or regular psychotherapy or therapeutic counseling, but people can call when in need and get get some immediate response and counseling.
Follow-up question, would you make a referral or connections?
When we can. I mean, we certainly have a range of listings. We don't refer to individuals, so we're not recommending particular people, but we may refer to agencies that provide counseling. The trick is for a lot of our folks is finding things that are free or affordable. So the degree that we have listings of sliding scale things and things that are immediately available or soon enough, because we're a crisis center, typically need something as quickly as possible. And so we do what we can to provide longer term referrals, but and provide that immediate bridging in the meantime.
You mentioned previous that there was a number that was being given to folks that are just in this room today. A number that flashed very briefly on the screen. If we were to call with questions or financial crisis to that number, and maybe you've already gone over this, but what could we anticipate in terms of a response from that number specifically?
Okay, so there were several numbers. I'm not entirely sure which one. I can say sort of broadly speaking, the question is whether or not you want to call and just ask questions about service or get information about service.
There was one number, and I remember you said it's just for the people in this room today. It was like a 614 number.
Right, so I'm not sure all of your roles here today. So that particular is for if I'm thinking, this is for the MCIF program, which is the Mobile Crisis Intervention and Follow-Up Team. So those of you who work in street outreach, so this is for harm reduction workers, street outreach workers, overnight drop-ins, and specifically for the St. Mike's ED. That number is for you. Otherwise, the regular referral number, the 9897 to the Gerstein Crisis Center, would be for anybody else to make a referral. Certainly you, as a person making a referral or a client who may be curious about service, can call and just ask questions about our service. We're actually even open to arranging tours. Sometimes people are very anxious about sort of reaching out to new people, and if we can have somebody come in and put meet us, sometimes that helps, so they sort of put us in their back pocket for a later date. We're happy to do that as well.
So when I use the St. Mike's, so the wellness, we call it the wellness program, so the 647 number and the 38 follow-up, sometimes they're very responsive, but they can never guarantee a bed. Is it best for us to call the regular referral number if we're really just looking for a bed and a 3-day stay?
Yeah, you can really do either or. There are no beds associated with the MCIF program. That doesn't mean you are shut out from access to those beds. That is not the intention of the program, is to provide crisis intervention in the community. That's always going to be the first thing that we try with everybody who calls, because really we only have 10 beds for the entire city of Toronto. That being said, the beds are in use for 3 to 5 days, so we have a fairly good turnaround. So if I don't have space available today, there's a good shot I'm going to have it tomorrow or the next day. What we try and do is recognize the need for immediate short-term beds, but also to recognize that so much can be done whether or not those beds are available. And so I'm going to sort of encourage you to think more broadly as well, that to allow us or to invite us to know that we're there to provide service whether or not there's a bed most immediately available. We're open to trying to work with that individual, whether or not the bed is available, and when it does come available, if that's appropriate, we'll certainly, work on that too. No. No, we don't maintain a wait. The question is whether or not we take a wait list. We're just call when you need us. Anyone else? Any other questions? Okay, thank you.
I have a question for the audience. How difficult is it to make a decision around which of these services to access for your clients, and what do you, how do you think about it? And I ask that because I think that information may be useful to some of the others here, just because there's so much, right? And is there anything also that we can do to make this information more usable for you, right, as workers? Yes. So the comment is that attempting to access mental health crisis services can be very exhausting and result in simply using the police services. And so it would be useful to know in the future if there are new crisis services that become available. Yeah.
So, first, so the question is just how difficult it is to access service, and I think that's, no one in this room is going to disagree with you. It is difficult, and we have so many folks with a range of unmet needs in our community, from housing to medical to psychiatric to just places where they can go and socialize and eat and drink and be in peace, and I think that's true. And it's frustrating both for the people we serve and for us as service providers. That being said, one thing that I'll put out there, and the MCIT are great, and I don't want to misrepresent my opinion of them. I do think they're great, and I think they serve a really valuable role in our community. But I think that we want to acknowledge that there is no other health need in our community that is accessed via the police other than mental health. And that isn't necessarily the entry point we want for the people we're serving. What we find with the MCIT teams is that about 40% of the folks they see are either arrested under the Mental Health Act, so they're taken to hospital for assessment, or there's some criminality that requires another kind of emergency intervention. Those are the folks who need to be with MCIT. The other 60% are the folks we can serve in the community. And I would encourage us to find ways, as Rochelle put, to sort of no wrong door, to find ways and patience and way to help each other to serve those people more effectively.
Yeah, and just around new services and gaps that you identify through your work, I would just encourage you to escalate those gaps and challenges to your managers. I'm sure you do, but there are planning tables in the Mideast community right now that are looking at particularly how to provide the most appropriate type of crisis service, mental health crisis service for homeless people. We're doing a lot of work around that, so be sure to speak about it in every opportunity you get around the need that you're seeing. We can also figure out a way to disseminate information around new programs that become available so that you know about them and maybe don't have to wait another, I don't know how long, till another session is offered with other speakers. So we can try to, I think, improve information around the services that become available. And maybe that's something to look at, including on our website with this series info. Stephanie?
I'm sure most of these things are connected to bigger platforms like 211 Toronto. If you were to look it up, maybe you see some of these services.
Or Toronto Seniors Helpline, where you call in and they
Right.
can direct you to mental health services that can support your client. Sometimes going to those bigger sources can help narrow down what's new and what's different that you may not have tried.
Yeah, that's a great suggestion. So Stephanie has recommended using 211 or the Toronto Seniors Helpline, just calling them and asking them about what services are available now in order to meet your client's needs, because they do maintain an updated list of that, right? Good, yeah. Okay, any other thoughts or questions on this? Anyone? No? Any further comments from the speakers you'd like to make? Okay, well then, we finished a little early, but feel free to stay around and ask questions one-on-one, and I'll send you the presentation material later today. Thank you for coming.
Thank you.